last session, and we'll make this efficient and educational. So I'm going to be discussing how we optimize the role of antiangiogenic therapy. And I'll just review with the current literature and point out some areas that are being developed currently. So essentially, we have two drugs which are approved in this space. The first is bevacizumab. We're all familiar with that. It's been approved for over a decade now, both in colorectal and non-small cell lung cancer. It was approved predicated on the ECOG 4599, which combined it with carboplatin paclitaxel, improving survival by approximately 2 months. However, with this improvement in survival came an increase in toxicity, including approximately 50% increase in terms of neutropenia and an increase in febrile neutropenia. Additionally, there were increases in non-heme toxicities, including hemorrhage and hypertension. And lastly, there were increases in grade 5 adverse events, primarily involving hemoptysis. And so in terms of safety, this is a more toxic regimen than carboplatin paclitaxel, with increases in grade 3 and 5 adverse events. And these were even more noticeable in patients over the age of 75. So moving forward, AVRPEARL-1 attempted to identify what the best regimen was with bevacizumab in terms of maintenance. And this took a combination of pemetrexed cis bevacizumab and then randomized one arm to maintenance with pemetrexed bevacizumab and the second arm with single agent bevacizumab. With primary endpoint of progression-free survival, it met its primary endpoint, improving progression-free survival, and did not show an improvement in overall survival, though it did trend in favor of PEM and BEV as maintenance therapy. So there were no new safety signals seen with this. It was a tolerable regimen, and again, no OS benefit, although it did trend in favor. The next one was Point Break, which was a phase 3 study, which was powered for overall survival. And this actually looked at a couple of different regimens. It looked at the ECOG 4599 regimen with bevacizumab as maintenance, and then it also looked at pemetrexed carbo-bev followed by pemetrexed bevacizumab. And as you can see from the curves, there's no real difference in progression-free survival, a slight trend favoring PEM and BEV, and then there was no overall survival difference. And in terms of age groups, you can see that essentially no difference, although the over 75 did not seem to fare as well with bevacizumab in the PCB regimen, the ECOG regimen. So as I mentioned, in terms of looking at these particular regimens, no difference in overall survival. PFS did favor the PEM carbo-bev arm with BEV and PEM maintenance. No difference in terms of the older populations. And unlike the ECOG 4599, they did not see a greater incidence of adverse events. So currently, this will be the study that rules them all. This will answer the question about maintenance therapy. It's going to take the carboplatin paclitaxel bevacizumab backbone, give that for 4 cycles, and then patients will be randomized into one of 3 arms, PEM, BEV, or the combination of pemetrexed bevacizumab. And when that reports out, we'll have a sense of which way to go. Now, in terms of toxicity, Corey Langer et al. Took a pooled analysis from ECOG 4599 and Point Break and looked at the elderly population. And just to show you, when 75 is, I guess, not elderly, or less than 75 is not elderly, and greater than 75 was considered elderly for this. And, you know, it's well balanced between those two age groups. And then looking at it, you can see from the forest plot that patients who are less than 75 did benefit in terms of an improved outcome. However, those over the age of 75 did not. And then looking at the pooled analysis for less than 75 of PCB versus Taxol Carbo, you see the less than 75 patient population did benefit, and those over 75 not so much. I think the hazard ratio was 1.1 for that group. And they broke it down even further, looking at, let's see if it's a particular age range at which this changes. So if you're less than 65, you benefit. If you're greater than 65, you benefit. If you're less than 70, you benefit, again, from the addition of bevacizumab. And over 70 benefited. However, the change was seen when you got down to greater than 75. You can see that if you got the triplet, the median survival is 9.6 months if you're over 75. And if you just got carboplatin paclitaxel alone, it was 13 months. Additionally, there were higher grade 5 adverse events in the over 75 group, 8 versus 5, and then higher rates of grade 3-5 adverse events as well in the over 75 population. And then looking at another area was whether or not you can give bevacizumab with in patients who have brain metastasis, and this looked at giving bevacizumab either with chemotherapy or erlotinib in the frontline setting or in the second line setting after having had brain metastasis managed, with the primary endpoint of looking at symptomatic greater than grade 2 CNS hemorrhage. And the take-home message from that was you can safely give bevacizumab in patients who have treated CNS metastasis. And as I mentioned earlier, the pooled analysis showed that there were higher rates of toxicity and no OS benefit seen for patients who are over the age of 75 with the regimen of carboplatin paclitaxel bevacizumab. So I mentioned this, although it's a phase 2 trial, because it's generated some interest. This is a Japanese study which looked at patients who are EGFR mutation, exon 19 or 21, treatment naive, had metastatic disease, and they were randomized in a 1-to-1 fashion either to erlotinib or erlotinib with bevacizumab with a primary endpoint of progression-free survival. And this study met its endpoint with an improvement in progression-free survival from 9.7 months for the erlotinib arm to 16 months for those patients who received the combination with bevacizumab. You'll remember that the beta trial was negative, but that was an all-comers study. And we'll talk a little bit more about where this is leading. So the next drug I'll talk about is ramucirumab, which was approved in the past year. And this is a monoclonal antibody. It works a little bit differently than bevacizumab, as it targets the VEGFR2 receptor. It's approved in gastric cancer, and it's also approved in combination with docetaxel in non-small cell lung cancer. So this is REVEL, which was a study designed phase 3. Patients who had refractory non-small cell lung cancer, previously treated CNS metastasis were allowed, as were patients who had received bevacizumab. They either received the combination of docetaxel ramucirumab or docetaxel alone, and this was powered for overall survival, well balanced, and it met its endpoint. It actually increased response rate by about 50% from 14 to 23, and improved progression-free survival also by about 50% from about 3 months to 4.5 months, and it had a modest improvement in overall survival of about 1.4 months. So this led to its approval, and it's now one of the options for patients. However, given the recent approval of PD-1 monoclonal antibodies, for those patients who are eligible to receive nivolumab or pembrolizumab, they're getting that. And this has now been relegated to third-line therapy or for patients who have some contraindication to receiving checkpoint inhibition therapy. Looking at this, you can see that the benefit was across all subtypes, including patients who had received prior bevacizumab, and then adverse events, not unexpectedly, and as we're seeing with bevacizumab, were higher in the combination arm, with approximately 49% neutropenia, increased rates of febrile neutropenia, and thrombocytopenia and mucosal inflammation. So in summary, for bevacizumab, it's still good with non-squamous non-small cell lung cancer, as long as the patients don't have a history or predisposition to hemorrhage, they don't have tumor that's cavitating or growing into a blood vessel. Maintenance therapy with bevacizumab seems to be better than bevacizumab alone, but there's added toxicity, and I don't know the extra mileage is worth the toxicity that's engendered. Over the age of 75, it doesn't seem to be a benefit, at least with carboplatin paclitaxel bevacizumab, in terms of efficacy, and there are increased rates of adverse events. And then lastly, based on the data from Japan, that phase 2 study of approximately 150 patients, there's an ongoing study in the US, again in EGFR mutation positive patients with the combination with erlotinib. Additionally, there are combinations now with PCB with checkpoint inhibition. In regards, Ramucirumab, again, this is approved with docetaxel in the refractory setting, either second or third line. It has very similar caveats as to bevacizumab. We don't have a biomarker for this, although they are analyzing samples and apparently are still analyzing samples from the phase 3 trial. And there are combinations planned or ongoing with EGFR inhibitors. There's even plans to go forward with some of the third generation EGFR inhibitors with ramucirumab, and there's an ongoing study with one of the PD-1 monoclonal antibodies in this space. So that is the summary of where we are with the angiogenesis. Questions?
Why you think ramucirumab seems to be safe in squamous patients second line when clearly it's not safe front line?
I mean, when bevacizumab is not safe front line.
Right.
I don't have an answer for you for that. I went through the literature to try and sort that out myself, and I didn't see a clear message behind that. Does anybody know? All right, it's unanimous. Right, so there have been a number of studies in head and neck with TKIs and with, I think there's an ongoing, or study that's going to report out with bevacizumab, and it's safe to do that, and I know 90% of them are squamous, but the experience in non-small cell lung cancer with bevacizumab was not good in the phase 2. And that's why it's a black box warning not to go there. So they do behave a bit differently. Maybe it's the location. Who knows? I don't know what the screening criteria are for some of the head and neck trials as well. They may. I know the one that we did, we were very cognizant of the location of tumor in terms of blood vessels.
So, the Bev had almost an identical trial design as RAM in the second line with docetaxel and was negative. Mm-hmm. What do you think about, the two? Is there a difference by, blocking the receptor in the second line setting versus, the ligand? Any thoughts on?
Well, I do. The drugs do behave differently, and they do work by a different mechanism of action. So I think that may in part explain it. Yeah. Beyond that, I think it'd be guessing.
It's interesting because again, gastric also Bev failed, mm-hmm. But so it seems like RAM is working where Bev was close but couldn't do it. But then, I don't know if it's, how much it's still minor activity or minor benefit, but it's interesting.
The benefit seen, at least in the lung cancer trial, was it was like getting on first base. You got a single there. It wasn't great. It was 1.4 months, but in the second line setting, we'll take that.
Till the PD-1s came along, that would have been very good.
Right.
But we see it in different. But it's interesting that it has been positive in settings that Bev has not been able to hit.
Right, and I would attribute that to the fact that it does have a different mechanism of action.
So
all right.
What's interesting in head and neck cancers, we've done a couple of studies, one in nasopharynx cancer with chemoradiation, and we're doing enough with BAF, and we didn't see any bleeding. And then we're doing right now with significant anaplastic thyroid cancer. We have not seen it. There's a trial for metastatic head and neck cancer for ECOG that's ongoing, accruing a lot of patients, and there's no interruption for bleeding. So I'm not sure why it's a difference, but it is. But we do watch patients very carefully in head and neck. So.
Right, and we did our own study at Anderson with one of the TKIs and had actually very good results in combination with chemotherapy and didn't have any bleeding issues. But again, in the lung cancer experience, it was very different with squamous cell. All right, so moving along, next up.